So we have multiple kinds of bleeds out there. We have esophagitis and peptic ulcer disease that can develop, right? So ulceration is the stomach that he's eating through and eating through and eating through until it hits a artery underneath and the artery starts bleeding, right? If it goes to the artery, then now you have a perforated bowel. It's going to perforate into the abdomen, and you're going to get free air in the abdomen, and that's a much worse situation, right? So we have to consider upper GI bleed would happen first, and then we can have perforation after that. You can even vomit so hard or heave so hard where you have Bohr-Heaves syndrome, where you have rippage and Mallory-Weiss tears of this lower esophagus, right? You can have varices that happen here, esophageal varices. We have gastritis, which is usually a precursor to GERD. And we have ulcers down here, duodenal ulcers versus peptic ulcers, right? So that's all under the umbrella of peptic ulcer disease, right? So peptic ulcer disease has two things, it has duodenal and it has what other kind of ulcers? Gastric ulcers, right? And those have complications, one of the complications being an upper GI bleed, which we'll be talking about, right? So we'll talk about peptic ulcer disease, we'll talk about GERD, right? And of course, GERD can lead to precancerous lesions, lead to Barrett's esophagus and esophageal cancer and such. But then we'll kind of end with variceal bleeds, which are our most severe bleed, right? So it's not a bleed that can wait till AM. If you identify someone has a variceal bleed, it needs to be fixed immediately, as soon as possible, right? There's no evidence out there that says it's okay to wait for variceal bleeds. You can wait for peptic ulcer disease. You can wait for gastritis, etc. Okay, so we have all this ulceration, right? It's just the amount of spiciness per country, per capita. Like India has one of the spiciest foods out there, right? Canada is up there as far as spicy foods as well. No, it's not. What's this down here? I think it's obesity. But anyways, you have Canada's pretty not great. All right, so we have not in real life, but anyways, we have a really spiciness there, and usually they say, oh, you got spiciness, that's going to cause ulcers. That's been completely disproven because down here is not obesity, it's the incidence of peptic ulcer disease. So if this was red up here, I should see red down here, and like it's less, right? It's like really Canada is not spicy, as we mentioned, right? It's the least spicy, and it has the most peptic ulcer disease. So what gives? Why is that? There's absolutely no relationship between spiciness and an ulcer. It's like saying like it's hot in summer and there's increased ice cream sales, therefore, and there's also increased sharks. So shoot, ice cream sales lead to increased shark attacks. That must be the reason. So upper GI bleed causes. All right, so here's a little summary right here. So you can see ulcers. 50% of our upper GI bleeds are due to an ulcer. How do you get an ulcer? You can have a peptic ulcer disease. Most common reason is H. pylori, right? A bacterial infection of our stomach, right? So our stomach gets a H. pylori infection in it, and that can then cause ulceration, whether the gastrum or the duodenum, right? And the guy discovered it, got a Nobel Prize for, nobody believed him that a bacteria could cause ulceration. Like, no, it's spicy food. I just came from India. They all have peptic ulcer disease over there. And they look at they look at the almanac and the World Book, letter W or letter I of the World Book. And this is back in the 80s, right? So they had Encyclopedia Britannica and such. I mean, anyways, so then they looked in there and no, there is not a lot of peptic ulcer disease in India. So what caused it? So he's like, I think it's bacteria. So then he just took a test tube full of bacteria and he downed it in front of all the scientists. They're like, what's going on? And then he came back a week later and he had peptic ulcers. So he's like, look, I did it, right? So then he got a Nobel Prize for that, and peptic ulcer disease. So yeah, so then you have to give, so that's why we give antibiotics for H. pylori, okay, or for peptic ulcer disease. Anyways, we have bleeding into the stomach. Technically, an upper GI bleed is anything that's above the ligament of Treitz. What the heck's a ligament of Treitz? It comes off the diaphragm. It's what supports the duodenum right there. So anything that's below that, so below the duodenum, is a lower GI bleed. Anything above the duodenum and above is an upper GI bleed, right? So that is technically the line in the sand that we say, okay? So like duodenal ulcers still counts. You'd think like, oh, the pyloric sphincter, that's where upper lower GI bleed, but no, it's at the ligament of Treitz, okay? So there's multiple causes, as we mentioned. We've got ulcerations of peptic ulcer disease. We've got variceal bleeds, which we'll touch on. That's only about 5% of our bleeds here, as you notice, but it's the most severe and the most deadly bleed. It's what people get admitted to the ICU for. So we see it a lot more than it really is seen in public, right? And then you have gastritis or esophagitis, right, from GERD and such, NSAID use, aspirin use, which can also cause our peptic ulcer disease as well. It's irritating, it's acetyl salicylic acid, right? So it's an acid that's going to irritate the lining of the stomach. And also on the back end, it actually increases acid secretion as well. So that increased acid secretion causes breakdown and gastritis, right? Erosions of the esophagus, and eventually that can lead to ulceration, where we have a bleed that develops, an upper GI bleed that develops, right? Oh, there's another ligament of Treitz right there, right? And then what else we got? We got vascular lesions like AVMs, like we talked about in neuro. We had AVMs of the brain that cause hemorrhagic strokes, right? We also have AVMs elsewhere, such as in the gastrum or the esophagus or the duodenum, and that can then cause a bleed, a GI bleed, right? And then, of course, neoplastic. So increased damage to the stomach over time can lead to, increased inflammation and increased tumor growth. And there's other certain things you can eat to make you have tumors, right? To inflame it directly. It doesn't have to be spicy food, which doesn't, or it doesn't have to be, it can be things that are like barbecued, or things that have acrylamides and things that have nitrates in it, nitrosamines, right? When you grill things and it converts it into nitrogenous products, which cause stomach cancers, right? And colon cancer, for that matter. And what else we got? So other kind of mimics just to consider, right? So posterior epistaxis. So someone has a nosebleed, epistaxis, right? That can, someone's like vomiting blood. It's like, oh, you're vomiting blood. No, it was just the blood at the back of the throat they're vomiting up. So we got to distinguish which one came first. Like, do you have a nosebleed? Where are you feeling this at, right? Is this painful, this bleed? It's not painful, really. The peptic ulcer is painful. The bleed itself is not. It's like when we get to variceal bleeds, they are absolutely painless. There's no pain associated with a variceal bleed. When someone has a bleed and they have like burning gnawing pain, well, burning and gnawing, if acid that's gnawing and burning does it happen after you eat? Yes. Well, shoot, that sound, and after I eat, I secrete gastric acid. So that's kind of putting the picture together. That's probably an ulcer. Whereas someone has a variceal bleed, doesn't hurt at all, right? And then they're going to feel nauseous because this is, remember what we say blood is? Blood is a irritant, right? Causes vasospasms in the brain. But in the stomach, it's going to cause irritation of the gastric rugae there, and where's it going to go? So use green, it's going to vomit, right? They're going to vomit all that blood, all right? That's going to be coming out. That's called what? Not epistaxis, but hemoptysis. Hemoptysis is coughing blood. That's a pulmonary process. Hematemesis, right? So emesis, that is hemat, right? It has heme in it. So hematemesis, epistaxis, hemoptysis, those are all different things, right? So that's the idea behind our different types of upper GI bleeds, right? So upper GI bleeds, we got hematemesis that can occur due to the irritation of the stomach, right, from the blood. And it's not hemoptysis, right? Hemoptysis is a coughing up of blood from the lungs. And what might cause hemoptysis? What might cause that? TB is classic, right? As long as they have the picture of like night sweats and weight loss, right? That's classic. Lung cancer has this as well, right? You could have pink frothy sputum, which is what? CHF pulmonary edema, right? Whether it be neurogenic pulmonary edema from a subarachnoid hemorrhage that erupted from an aneurysm, okay. But more commonly, it might be heart failure, right? You look, see if someone has edematous feet and they got they have the right medication profile that says CHF. Okay, so we got hematemesis and we have coffee ground emesis. So coffee ground emesis is coffee ground appearance. It's blood that's been in here for a second, right? It's starting to be digested. So we're starting to digest this blood, whether it be a little bit or it be a lot of it. That's going to cause a breakdown of the blood, and then it's going to start getting oxidized, right? Just like if you put what else gets oxidized, I'm thinking of like avocados, right? Get oxidized. So it's going to oxidize, or I should say rust, because that's what heme is made of, right? So iron gets oxidized, it's going to turn rusty outside. Or your avocados. Your avocados don't have iron in it, don't worry, right? Or don't have rust, but they are going to, get oxidized. They're going to change colors. Okay, and that is what coffee ground emesis is, right? It's still irritating. They might try to muscle through it, but it's irritating blood, and it's going to be ejected, right? If it's not ejected, it can then be ejected south, right? It can be such a fast bleed that it comes out through the anus, right? So you have a lower GI bleed is always an upper GI bleed until proven otherwise, right? So a very fast upper GI bleed can have hemato what? Hematochezia, right? So hematochezia. If you're Italian, hematochezia, right? So it's going to be, it could be either one, but it's a bright red blood per rectum. There's another abbreviation you might see. Bright red blood per rectum noted on exam. Okay, and then if it gets oxidized on the way down, it's been oxidized, but also has been fermenting. What's a better word for that? Not kombuchaing, but what else? It's been digested all the way down. It's starting to get, I think oxidized is a good word. It's being digested all the way down, and then it's going to start to smell, right? And it's going to come out as what? Not coffee ground anymore, but sticky, black, tarry, right? And that's called melena, right? So melena, the pretty name of melena is now black tarry stool. That is oxidized GI bleed, right? And that's definitely an upper GI source. Rarely it could be like on the right side of the colon, maybe. It might be coming from over here, but most commonly it's an upper GI bleed when it's when you have melena present. Right, and then the other piece, if you are digesting it, right, what does protein have in it? What does hemoglobin and blood have in it? Is protein. All right, so when you have blood in your stomach, oh, there's blood, something to digest. I know what to do. I'm going to release pepsin. I release hydrochloric acid, and that's going to break down the RBC and the hemoglobin. Hemoglobin has heme and globin, right? Heme is the iron, which is oxidizing, it's smelly, and you have globin, which is a protein, right? So you start eating, you're eating protein. So you just gave yourself a little turkey dinner, right? You got a little high protein content drink right there, right? So it's like, I don't do protein shakes, I do GI bleeds, right? So that's what vampires say. And so you have this high protein content in your gut, and then you're going to start absorbing it, right? You start absorbing the protein, and then what do you do with excess protein? Your body breaks it down into BUN. So when you see a BUN elevated on labs, it could be a GI bleed, right? And with these ratios here, we'll talk about these in renal. The normal ratio for BUN creatinine is what? So normal is about 10 to 20 to 1, right? 10 to 20 to 1. So creatinine of 1, normal BUN 20, right? Creatinine of 1, normal BUN 14, right? So 10 to 20 to 1. It's a 20 to 1 relationship. If it's more than 20 to 1, when we talk about renal, that's pre-renal. But when it's more than 30 to 1, creatinine 1, BUN 40. Well, shoot, why is my BUN 40? It's because I'm breaking down proteins, right? So I could have a GI bleed. Another common reason is breaking down proteins is with steroid use. Steroids stimulate proteolysis and break down proteins in the body. Okay, and also steroids cause peptic ulcer disease. So it's a 2-for-1 right there. All right, so that's the overview of our upper GI bleeds, right? There are other rare things that could cause GI bleeds, but these are the most common ones. We'll touch on Mallory-Weiss tears as well. We'll touch on some vascular abnormalities like Dieulafoy's lesion, which is a really fun one to say, Dieulafoy, right? And then you have some cancers that can occur as well. Esophageal cancer, gastric cancer can cause bleeding, but also causes that weight loss. It causes what are called alarm symptoms. Okay, so we'll talk about these coming up. So peptic ulcer disease is first, right? So we are eating away from a normal mucosa to a not normal. So it is literally eating away at the vasculature, and now the blood supply is being exposed. And it can eat all the way through and cause a perforation, right? Which is our worst case scenario. So again, it's 50% of our upper GI bleeds, and it's due to too much hydrochloric acid or too much erosion from something we did. Like we said, aspirin, which is an NSAID, is directly toxic to the gastric lining itself. So NSAID use, chronic NSAID use, is an important history to gather to say, do you take what? Ibuprofen is a good one, right? They take, colecoxib and other different other NSAIDs out there. There are only certain ones that are over the counter, other ones need to be prescribed. Usually someone like rheumatoid arthritis or arthritis, you're thinking is NSAID use, right? Classically, someone has a headache and they took like 5 ibuprofens. It's like, that's the reason I have a GI bleed right now, right? So, or they have back pain and they're taking a lot of Motrin or ibuprofen, and that then leads to now a GI bleed, right? They're not coughing up blood, because hemoptysis, they're vomiting blood. That's hematemesis. So NSAIDs are directly toxic. They also block the COX enzyme, and that's going to, these guys block the COX enzyme, and they're COX blockers, and that's going to decrease prostaglandins. Prostaglandins are protective of our stomach, right? We know prostaglandins are inflammatory in the inflammatory process, but in the stomach side, it's protective. It stimulates mucus release, which protects your stomach, and it's good. That's good. We want the mucus there to protect our stomach lining. And if we don't have, if we give NSAIDs, we don't have mucus, we're going to have breakdown of our stomach lining, right? Smoking is directly toxic. E2H is directly toxic as well to our stomach lining. And then we said decrease mucus production. So the mucus production is not being produced because we are using up all our bicarb in our body. It's being used elsewhere. We have slow blood supply to the area, and hydrochloric acid gets absorbed, and then bicarb gets secreted. But if this is really, really slow moving traffic, that's going to, your hydrochloric acid can no longer go into the bloodstream anymore. It's just going to stay back in the gastrum, right? In the gastric lumen, and therefore it's going to be more breakdownage. Okay, so back to NSAIDs. NSAIDs not only directly are toxic to the gastric lining, but they also are going to go work on the back end and decrease the mucosa, right? So they're going to cause a breakdown of our lining from both ends. It's decreasing mucus production. It's also going to directly be toxic to our lining of our stomach, right? And then gastrin. So H. pylori increases gastrin, and gastrin is a natural hormone that increases hydrochloric acid. So that's what H. pylori is doing, is cranking up all the acid secretion in the stomach so that we have more acid around, right? Because H. pylori is going to wreak havoc and lead to ulceration and thus our GI bleeding, right? We've heard of stress causing ulcers, and it's like, you always hear moms say, "You're going to give me an ulcer," right? That's not mom. It's not going to happen. It's E2H and smoking. Shh. It's your lower back pain you're taking Motrin for. No, I'm kidding. So it's not ulcers that are caused by stress, but from just regular psychiatric stress. It's little stress from body-wide stress from the ICU setting. That's what causes a ulceration, because stress releases corticosteroids, and corticosteroids are involved in promoting hydrochloric acid secretion, as we'll point out in the next slide. Okay, so what else? So 90% of the PUDs are caused by H. pylori. That's why the guy won a Nobel Prize. Okay, and how do you know? What do you need to do in this situation? They need to get an EGD. You go to EGD, go into the stomach and take a little sample, see if there's H. pylori there. And also they can look around and take a little sample, see if there's tumor there. They can go in there and they can get a history as well to figure out what's going on. But it might just be a little bit of breakdown, or it might be a lot of breakdown to the point where the blood vessels have been exposed, and we might have to go in there and put little clips and clip off the arteries that might be bleeding. Okay, so PPIs, those are proton pump inhibitors, pantoprazole, omeprazole, they all end in prazole. Right, they're better than H2RAs, histamine 2 receptor antagonists, and we have a slide dedicated to these guys. And so we're giving these guys to suppress the secretion of acid, which makes sense. If acid is causing the problem, let's get rid of the acid, right? So that's the idea behind anti-secretory therapy. Mucosal barrier therapy, they're going to put a little coating of Pepto-Bismol in the stomach, and that's going to provide like a mucus layer, false mucus, or let's not pretend, but a substitute mucus layer, right? And then we got to eradicate H. pylori. So we know H. pylori can cause it, and we can stop the hydrochloric acid production, but let's go ahead and give H. pylori, or get rid of H. pylori. So how do you do that? H. pylori is gram-negative, so we have to give gram-negative stuff, and it's also in the stomach, which is an anaerobe. So that's why we're giving gram-negative stuff, and we're giving anaerobic stuff, right? Did I say that right? It's a complicated ulcer, so it's 4 to 6 weeks. I believe it's gram-negative. I might have misspoke. All right, so yeah, so the complications, why we're here in the first place, that's why we have bleeding, right? So bleeding is happening, and then perforation is another consequence of our peptic ulcer disease. Okay, so this imbalance of hydrochloric acid and mucus is what's causing erosion of the mucosa, and we get our hematemesis there. We can get melena and coffee ground emesis as well, but are they going to have pain? Yeah, they're going to have some pain as well, especially with eating or after eating. And they like to break it down as a science, but it's not exact. That's not an exact science. Right? Like every gastric ulcer gets more serious once someone eats, right? Because when you eat, hydrochloric acid gets secreted, and you think, well, if I eat, that's going to cause a right? Does it happen with eating? Well, it's aggravated by eating. Yeah, most of the time, but it's not like 100% that it always happens. It could be either one. Okay, so there is a difference between the two. All right, duodenal ulcer usually is after the stomach's all done with all the acid, it secretes it 2 to 4 hours later. So usually it might happen 2 to 4 hours after you eat is why you have a duodenal ulcer, right, versus a gastric ulcer. But it's not always true. Okay, so but gastric ulcers keep irritating the stomach and cause cancers, right? Vomiting is going to be associated because it's irritating the stomach right there, and they can easily vomit up that blood. Okay, heartburn, as that acid is going to build up, and it's going to start, as they vomiting, it's going to cause more irritation in the lower esophagus. All right, so gastric acid pharmacology. So we have what we want to do is decrease hydrochloric acid. So eliminating H. pylori will do that, right? Getting rid of H. pylori will get rid of the hydrochloric acid production, which is what's causing a damage to our stomach in the first place. We can provide mucosal barriers, that's with our sucralfates that we did, right? Or we can increase mucus production by getting rid of the prostaglandin inhibitors, right? So getting rid of NSAIDs is an option, nice basket. And the other option is to do a increase bicarb. So we could get avoid steroid use. We can have other options to improve this whole homeostasis within the gastrum, right? And I mentioned, restoring blood flow is an important piece, right? Because blood flow comes in, right? And then it should go to the venous side. So there's our gastric goblet cells. You just kind of zoomed in right here, right? And all this hydrochloric acid is all built up here in the gastrum, right? And it's ready to get reabsorbed and then washed away. But when you have low flow to the stomach, when you have an SNS response, for instance, right, that hydrochloric acid is going to get backed up, and it's not going to be able to get out, right? So one of the ways to fix that is fix the shock state, right? If you give vasopressors, it's going to vasoconstrict more and worsen the ulceration. This is why in the ICU we give what? We give PUD prophylaxis, right? For everybody who is in a shock state, for instance, right? And the other piece we can do, besides improving perfusion and fixing their shock state and fixing the underlying problem, is to improve blood flow. It's like, well, I thought you just said they had a shock. Well, how do you improve blood flow to the gut? Yeah, you feed them, right? So you put food in there along with the shock state, right? So you got food in here as well. Now you're going to start vasodilating a little bit and getting a little extra activity. It doesn't have to be like a full turkey dinner. It could just be 10 mLs an hour of just tickling the gut, right? It's called tickle feeds or trickle feeds, right? So you're just tickling the gut so that it doesn't die, for one, and they get an ileus, because oftentimes like, oh, it's day 10. I guess we should feed them, right? They weren't getting better when we starved them for the last 10 days, so maybe now they'll get better, right? So, but also it's going to provide some supply of blood, a little bit of supply. We're not rerouting everything to the gut, right? We're still saving some blood supply to reroute to the areas the SNS wants to go, to lungs, muscles, brain, and heart. So early tube feeding is a good way to avoid ulceration as well. And of course, we do PUD prophylaxis to stop the proton pump, right? Proton pump inhibitors are an option, and usually proton pump inhibitors, like I said, are the better ones because they are blocking like all the action. If we zoom in here and we look at our parietal cell right here, it secretes hydrochloric acid into the stomach lining or into the stomach gastrum or lumen. So if we give a proton pump inhibitor, it's blocking that directly. That's all. It's blocking the actual business end of the hydrochloric acid factory, right? Whereas we give like a H2RA, a histamine 2 receptor antagonist, what is it blocking? It's blocking one part of the parietal cell. The parietal cell is activated by CCK. It's inhibited by prostaglandins, which is why if we're inhibiting prostaglandins, we're inhibiting the inhibition of the parietal cell, which is going to make more hydrochloric acid. We're also not blocking the vagus nerve on the muscarinic receptors. We're not blocking the steroid receptors. We're not blocking a lot of things, gastrin as well. So it's only like 1/5 as powerful as Protonix or pantoprazole. So that's why if we do have an ulcer, confirmed ulcer, we do have shock states, we do have a neuro injury with an SNS storm, it's better to be on pantoprazole. right? So we got high-risk patients, right? A trauma patient. We have a sepsis patient, right? We have a severe burn. These are all severe injuries. These guys that are on high-dose corticosteroids. What do steroids do? Steroids block this whole process here. So let's do like another one here. So we have our proton pump right there, secreting hydrochloric acid into the stomach, right? HCl. And then we have a muscarinic receptor from our vagus nerve there. We have our, what else we have? We have our prostaglandin receptor. We have our NSAIDs, and we have all these different actions that are blocking all these guys here, right? And steroids are blocking prostaglandin production, right? If you look at the whole pathway of how it all breaks down, right? The cyclooxygenase, the COX that's in there, that's only like step 3. Step 1 were steroids blocking the production of prostaglandins in the first place, right? So all these prostaglandins that get produced here, like arachidonic acid and prostaglandins, I thought I had a good picture of this. But we have all these prostaglandins are getting stopped made in the first place, and we know prostaglandins in the stomach are beneficial. So that's the idea behind, steroid use needs to have pantoprazole, right? A PPI of some sort. Now, why don't we use omeprazole? Because it's just the way it's dosed, right? Omeprazole, I think, is dosed BID, whereas pantoprazole is dosed daily, so it's a little easier to dose as well. Okay, so to recap, our parietal cells produce hydrochloric acid, and they're inhibited by prostaglandins. So if we give NSAIDs, which inhibit prostaglandins, that's like an inhibition of the inhibition. So that's going to increase my parietal cell activity, increase hydrochloric acid, right? Acetylcholine, right, is stimulated by the vagus nerve. That's going to also increase my parietal cell activity. Gastrin is our normal activity here. That's how we normally increase hydrochloric acid, right? When there's a protein content in the lower stomach in this little area right here, it's going to release gastrin and say, hey, there's protein, so say no more. And then it starts releasing hydrochloric acid, start breaking down the protein. It releases pepsin as well up at the chief cells, but really the action happens over here in the pancreas. Okay, so what else? We got these ECL cells. They produce the histamine. They are protective. We have they produce histamine 2, which is going to be we want to block that with our H2RAs, right? And we got gaseous cells, like I mentioned. They get released by protein in the stomach. And we got our somatostatin cells. I bring that up because we have a drug called somatostatin, or octreotide, right, is the other name for it. And we give octreotide because it's beneficial to someone who has a ulceration, yeah, a little bit, but it's really beneficial because it really just shuts down the GI tract. It's going to shut down, it's going to vasoconstrict as well, the GI tract. So if someone has a GI bleed due to varices, which is usually swollen vessels, let's go ahead and not make them swole by making them vasoconstricted, and that's going to help out. Okay, what else? So mucosal cells, they produce the bicarb, they produce the mucus layer, which is protective. So we want to have that in place, and look at prostaglandins are involved with that as well. So prostaglandins we want to have around in the stomach, and so we don't want prostaglandin inhibitors. Who inhibits prostaglandins? NSAIDs and steroids, right? So PD prophylaxis, we want to get it on board within 48 hours, right? The stress activity we talked about, the stress itself is going to stimulate, it's going to release steroids, which blocks prostaglandins and therefore cause more hydrochloric acid. But also the primary mechanism is that we have a shock state happening, right? We have decreased blood supply to the gut, and that's going to lead to decreased perfusion and decreased elimination of the hydrochloric acid that's trying to leave the stomach, right? But instead it stays behind, and it's going to cause a further breakdown of the stomach. Okay, so that's how we, the medication we give. So pantoprazole and H2RAs, they all H2RAs end in what suffix? Tidine, right? So it's like cimetidine, we have famotidine, right? So these are the different H2RAs. They can be great for someone that needs PD prophylaxis, but they aren't super sick, that they just need it because they are high risk in the ICU. All right, so moving on to GERD. So GERD is about 30% of our GI bleeds, right? This is where it's called a brashing of the acid. The acid's going to, usually it bounces up against this lower esophageal sphincter, and that sphincter is super weak, right? And it's like, oh no, my hole. And it's going to get all the acid is going to be brashed up against the lower esophagus. That causes a lot of burning. and that's going to be uncomfortable. And yes, it's uncomfortable, but then eventually it can lead to a little bit of ulceration or gastritis and can cause a little bit of a GI bleed. Okay, but the other complication, of course, is cancer. It can just chronic inflammation and chronic irritation of that stomach lining and of the esophagus, and that can lead to a neoplasm of some sort, whether it be esophageal cancer or a gastric cancer. Okay, so it's all about the lower esophageal sphincter tone with these guys. So like with nursing, school, and outpatient things, you recommended different foods to eat, right? Things that would not relax the lower esophageal sphincter, because you want that lower esophageal sphincter to be super, super tight, so nothing's getting through. And of course, you talked about positioning to make sure the position was upright, so that's not going up against the esophagus, right? There's all kinds of pillows you can buy on Amazon. There's all kinds of different steps you can do. In the ICU, what can you do? It's like one of our lower totem pole issues, right? It's not something we're really going to worry about that much, but it's something we can consider, right? We can say, oh, that's why they had the GI bleed. It doesn't usually end up as a severe situation where they're on pressors and require blood transfusions, right? Unless they let it go for a long while and they have anemia because of it, because they let the RBCs get low over time. Okay, so Barrett's esophagus is a significant complication that leads to cancer. We have the hematemesis, right? And got a cough that can develop if they all this acid starts getting up into their system and goes up, and then while they sleep, it makes its way into the trachea and causes asthma. And adult onset asthma is usually due to GERD of some sort. Okay, so what do we do with these guys? They're going to do an EGD and they're going to biopsy it. They say, oh, you got gastritis, or you got GERD, right? Or you have a hiatal hernia, and that puts you at risk for GERD as well. So they biopsy it to make sure it's not what? Not cancerous, right? So they might get a PPI, but usually they don't. Usually it's more lifestyle adjustments, right? They give them all tips and tricks on how to change their ways, right? So different foods, but not spicy. We said that wasn't a thing. But coffee, soda, nicotine, all these things relax that lower esophageal sphincter, and then fluid or acid can brash up against the esophagus. And then just to talk about the cancer, one more thing is alarm symptoms to be alert to. So someone comes in with a GERD, and a long-standing GERD, and they have weight loss history over the last 6 months. That's an alarm symptom where they might have cancer also, right? And of course, the GI bleeding, that's kind of the intersection we see them at, and that could be a risk. That could be the cancer is eroded into vessels and causing the GI to bleed. And then dysphagia and odonophagia. These are where they have the cancer is kind of compressing the esophagus. It's difficult to swallow, or it hurts to swallow, or it's ouchy to swallow. That's ouchy is O. And then what else? They have their age is higher. They have a higher risk for cancers.